July 20th, the sun is burning, kind of, and here we are for another BRAINCAST. My name is Pospo, and I know I promised I'm going to have a haircut. As you can most probably tell, it didn't happen. I can come up with many excuses, but the truth is that I'm helpless and barberless. As my barber decided to move out from Hackney. I know I can go to someone else, but I feel a deep connection. Anyway, that's not the reason you're here. So last week, we had Prof. Trudy Chowdhury talk to us about cognitive behavioral therapy and the wide range of applications it can have, from anxiety to pain and even dissociative symptoms. This Monday, we don't have a professor, but I bet my hair that he will become one before I can find a new barber. Dr. Emmert Roberts is a Medical Research Council Clinical Research Fellow in the National Addiction Center, but also an active clinician in substance misuse psychiatry here at the University. I gotta say that he loves his studies, as he graduated with distinction in medicine from Oxford and epidemiology from the London School of Hygiene and Tropical Medicine. And as it's one member, easily enough, he's a member of both the Royal College of Physicians and Psychiatrists, and yes, he does research in addictions. But before we go into all the relevant details, let's start with the basics. Emmert, welcome to BRAINCAST.
Hi, Pospo, long-time listener, first-time caller.
So, let's start with the basics. When did humans start drinking alcohol?
So the short answer is for as long as they've been around. So we actually have anthropological evidence that pre-human ancestors were drinking alcohol. So they were taking fermented fruit as it fell from the trees, and they were consuming it even before humans came on the scene. But if we're thinking about more sort of traditional alcohols or ones that are manufactured, then we have to go right back to the ancient Egyptians in around 5000 BC. And that's when we have the first documented evidence of any sort of production of alcohol. And actually, the very first recipe ever documented in the world is for beer. So beer is the oldest sort of manufactured alcohol out there. And yeah, we've been drinking it for a very long time.
Wow, to be honest, I wasn't expecting that. I would expect to hear wine, but not beer. But anyway, I trust you. So due to my heritage, I can't help but mention the ancient Greeks. Don't worry, I'm not going to ask you to give my marbles back. But I was reading an article by Dr. Davidson, one of the many British historians that fell in love with ancient Greece. So he described the way the ancient Greek elites would drink alcohol in symposia, which back in the day, they were the epicenter of culture. But it seems that alcohol was consumed in a way more formal way. It was tightly in with rules, customs, rituals. So very different to the way that we consume alcohol today. So what happened in the meantime?
Yeah, so you're right. So alcohol, the way alcohol is consumed has changed a lot, obviously, over the course of it being drunk since the beginning of human history. And it's really been dependent on setting. So as you say, in sort of more ancient civilizations, it was consumed in group settings, in more formal areas, perhaps as part of rituals. And we've moved away from that into the sort of modern era. And the way we kind of think about how alcohol is drunk or purchased or consumed at the moment is we split it into the on-trade and the off-trade. So the on-trade being alcohol that's bought in pubs, restaurants, etc., and the off-trade bought in supermarkets, off licenses. And what we see over the course of sort of the past 20 or 30 years in particular, looking at the UK, is that the purchasing has moved way more to the off-trade. And that's due to a variety of reasons, cost, availability, but it's also cultural. So we are now a nation of drinkers that typically drink more at the home than we used to. We've moved away from drinking in pubs and restaurants, and the vast majority of alcohol that's consumed in the UK is consumed at home, either in groups or on your own.
I have to say, because you mentioned culture, that when I moved to London back in 2009, I noticed a stark difference between how Greeks and Brits consume alcohol. It's a completely different attitude. So what do you think is the influence of culture on alcohol use disorders?
So the UK is not the worst in Europe in terms of binge drinking patterns. That may come as a surprise to some of you. It's not great, but it's not the worst. So the Eastern European countries and the Baltic nations typically drink more alcohol per capita than the rest of Europe, and they tend to drink it, or they have more common binge patterns as well. But yeah, you're right. Culture is hugely important in how people drink and the amount that they consume. So if you look at women and men, for example, again over the last sort of 30 years, it's become much more socially acceptable for women to drink. Previously, you sort of pubs and various other establishments were quite exclusionary to women, and particularly around alcohol consumption. That's changed, so it's about, while men still get more alcohol disorders than women in the UK, women are catching up quite substantially. And then there's also the impact of religion as well. So certain religions obviously have more prohibitions around alcohol, Islamic faiths in particular. And the prevalence of alcohol use disorders is typically lower in those populations. That's not to say that they don't exist. So yeah, culture has a huge impact on the volume, the frequency, and the pattern at which people drink, and it should always be taken into account when doing an assessment and asking about alcohol.
I mean, what I find extremely interesting is that alcohol, despite the detrimental impact it can have on people's lives, it is widely, I would say, acceptable. I mean, you wouldn't hear in discussion people, openly talking about the drug use, but certainly, you go out and you hear people bragging about, how many pints or how many shots they had. So how has alcohol managed to overcome the negative stigma of other substances when it comes to recreational use, of course?
A great question. So I think there's probably like two main ways that separates it out from other drugs or other illicit drugs. One is it's been around for absolutely donkey's years, as we've said, and so it's much easier for legislators and sort of policymakers to ban or regulate new substances or new things that come onto the market. Alcohol has been around for, as I've said, forever, and so any kind of restriction or imposition of sanctions on alcohol is incredibly difficult, and that's probably made more difficult by the sort of disastrous consequences of prohibition that we saw from America in the 20s and the rhetoric around that. Actually, if you look at the sort of literature around prohibition in terms of alcohol harm, it did all right. It reduced the level of alcohol harm, but it just caused a lot of other chaos. So I think, so it's an old substance that is relatively well known, and that insulates it slightly from other uses and makes it more socially acceptable. And then the second thing is that by the very fact that it's legal, it has an industry out there that is lobbying for its continued use and in order to make profits for its shareholders. So the alcohol industry is obviously driven by profit. It has a fiduciary desire to increase availability, increase affordability, maximize its shareholder profit for its shareholders, and thus you create a system whereby this industry can have huge influence on governments, huge influence on people through marketing and education, and that shouldn't ever be discounted. So one of the reasons that alcohol is so abundant and insulated and socially acceptable is the fact that it has a huge amount of lobbying behind it internationally.
I know it's a pretty standard question, but still. So how common are alcohol-related disorders?
So, the main way that we measure this in the UK is through surveys. So the big adult psychiatric morbidity survey that's conducted every 7 or so years, and the last one of those was done in 2014, and that estimates that about 20% of the UK population has some kind of problematic use of alcohol. So they use an audit questionnaire, which is a pretty common standard questionnaire that we use to screen for alcohol disorders, and anyone scoring above a score of 8 is thought to have problems with alcohol. So it's in some way negatively affecting their mental or physical health. So of that 20%, about 1% overall. 1% of the population in the UK is alcohol dependent, or has alcohol addiction, or is having symptoms that would be associated with being addicted to alcohol, and the rest are using it harmfully. So it's having some kind of negative impact on their mental or physical health. Now, the problem with those surveys is obviously that they tend to underrepresent the kind of people with alcohol disorders. So one, people lie on surveys, fine, and two, they don't typically involve prisoners or the homeless population or people who might be more socially excluded. And we know that alcohol use disorders are more common in those populations. So 20% is probably a conservative estimate, but 1 in 5-ish of people in the UK have some kind of problem with alcohol.
And I mean, on the same note, how many people out there think they don't have an alcohol problem when in fact they do?
It's really difficult to measure because, people lie, and it's really difficult to get an estimate of sort of the number of people who might be at risk compared to the number of people who say they're at risk. But we do have certain kind of methods to try and pick apart those things. So we can model it. So we can look at, and what we normally use to model it is alcohol-related hospital admissions. So if you've got a problem with alcohol and you're going to hospital because of it, or it's picked up in hospital, that's a relatively, the rates of those hospital admissions are a relatively good proxy for measuring how much exactly alcohol problems are out there. So we use that as a model, and we add in things like the level of homelessness, the level of social exclusion, and we can use that to come up with estimates. And so what Public Health England do, one of their jobs is to sort of monitor the alcohol consumption across the country, and they split it up into local authorities. So they use this model and they come up with a number for how many people they think should be in specialist alcohol treatment, and then they look at the numbers of people who are actually going into that treatment and they compare them. And if we look across England, the best local authority out there only gets 50% of people with an alcohol problem into treatment. The worst gets 5%. So even at the best of times, the NHS and its sister organisations and everyone who's treating alcohol disorders really struggle to access everyone out there with an alcohol problem. Even when we're doing our best, we're only seeing half the number of people out there.
I mean, since you mentioned the hospital admissions, you recently published a meta-analysis in one of the biggest journals in your field, Addiction. Congratulations. So you looked into the prevalence of people with alcohol-related disorders in UK hospitals. Tell me a bit more about that.
Yeah, so this was a couple of years ago. You may have seen this on the news. We had some headlines, and there were lots of newspaper headlines sort of saying 1 in 10 people in hospital is a drunkard and boozing excessively and doing all sorts of things. So yeah, we basically did a systematic review. So we looked at all the papers that had ever been published that reported the prevalence of an alcohol problem in UK hospitals. So ranging from falling over and breaking a bone due to alcohol intoxication, right up to alcoholic liver disease and alcoholic hepatitis. And we looked in particular at the mental and behavioural disorders that are due to alcohol, that are defined in the ICD-10, the Big Book of Diagnostic Codes that we use. So we looked for harmful use of alcohol, so it having a negative effect on your mental or physical health, and we looked at alcohol dependence, so commonly referred to as alcohol addiction. So you're having symptoms that suggest that you're physically and psychologically dependent on alcohol. And we looked at those two things. We ended up with about 1.6 million patients over the course of sort of lots of years that papers have been published, and we found that 1 in 5 people in hospital was harmfully using alcohol, and 1 in 10 was alcohol dependent. So roughly, you add those up, you get about 30%. So roughly 1 in every 3 people who's entering a hospital in the UK has some kind of problem with alcohol. And 10% of the entire population is alcohol dependent, and that's enormous. So we, as addiction psychiatrists, we were like, that doesn't sound unreasonable to us. But a lot of our colleagues in the acute hospital sector were really quite surprised by the magnitude of those results. And I suppose the main thing that we sort of take from that is that alcohol is, we can come on and talk about the sort of funding situations, but it's severely underfunded. And if you look, a third of people in hospital have got some kind of alcohol problem. It's a really golden opportunity to be able to treat them. Now, acute hospitals have, diabetes specialist teams, dietetic specialist teams, etc., for a variety of conditions, and all of those have a lower in-hospital prevalence than alcohol use disorders. So we think that our data sort of advocates for an increased amount of awareness in acute hospitals and all hospitals, and advocate for specialist alcohol care teams. So Public Health England sort of body that oversees alcohol and drug epidemiology in the UK, has said that, yeah, the 25% top affected hospitals in the UK should get extra funding to get alcohol care teams. We think that should be 100%, given the prevalences and the amount of comorbidities that are occurring due to alcohol and all these.
I mean, yeah, you're absolutely right. The numbers are staggering. And the thing is that nearly 60% of local authorities have slashed budgets for addiction services last year amid government cuts to public health grants. And the number of training posts, I mean, correct me if I'm wrong, so the training posts in addiction psychiatry decreased by 60% since 2006. So is this getting any better, or is it that bad?
No, it's actually getting worse. So it was 60% last year. We're now down to 12 posts in England and Scotland and Wales, 12 SPR addiction psychiatry posts. And it used.
I'm really sorry to interrupt you, but it doesn't make sense.
You're preaching to the choir, Pospo. I know. I suppose just to give a little bit of background of people who might not be aware of the sort of addiction landscape in the UK. So it used to be, before 2012, that about 95% or so of services, addiction services in the UK, had some form of NHS input or had some form of NHS sort of factor into their treatment delivery. In 2012, the coalition government passed a thing called the Health and Social Care Act, and that transferred the responsibility of commissioning drug and alcohol services solely into local authorities, and it removed the ring-fenced budgets as well that were around drug and alcohol treatment. So it had two main effects. One, as you've said, it's caused a massive disinvestment because these budgets are no longer ring-fenced and they're just part of public health grants to local authorities. So 250 million has been removed from drug and alcohol treatment budgets since 2012, which is crazy high. Like, that's an enormous amount of money. And the second thing it's done is that it's opened up competition within the addiction sector. So whereas prior to 2012, about 95% of services had some form of NHS input, now we're down to about 35%. Wow. And that's led to a whole bunch of things happening. So in some areas, it's led to increased innovation, and local places getting the sort of local aspects of things that they need, which is great, which is what proponents of the law were saying. But it's also meant that that quality is incredibly variable across the sector, and cost becomes one of the main drivers for commissioning a service, which is can cause problems in terms of a race to the bottom and in terms of treatment delivery.
And then COVID came into our lives. So people in lockdown, people bored, or even stuck with people they don't necessarily need to spend time with.
Yeah.
So maybe alcohol use increased. But on the other hand, I'm thinking, pubs were closed, social gatherings were banned. So maybe alcohol use decreased. So how has the pandemic affected the alcohol habits?
It's really mixed. So it's not often helpful to sort of look at the whole population in terms of change of alcohol, because some people are going to go down, some people are going to go up, so it might look like everything is the same. There's been a whole bunch of surveys and stuff done on changes in drinking due to lockdown, and they all show quite a mixed picture. So very roughly, because there's a whole bunch of them and they all say slightly contradictory things, but roughly 3/5 of people have either stayed the same or drunk a bit less in lockdown, and 2/5 of people have increased their drinking. Now, the problem is that those 2/5 of people include most people with alcohol problems. So the people who were problematic drinking before the lockdown started are more likely to have increased their drinking subsequently due to lockdown. And because everything has become more virtual, because of the problems that I was just saying about in terms of the variability in access to drug and alcohol treatment across the UK, that's meant that people have really struggled to access services even more than in normal times, and it wasn't great in normal times. So yeah, there's huge problems because of the pandemic.
I mean, I was reading a letter to the editor of Psychiatry Research, the journal, and so the author was suggesting that drug use can increase the risk associated with the coronavirus infection. So is there any similar evidence for alcohol use?
Yeah, so there's a couple of things. So one, obviously, you need to actually go and purchase your alcohol. So that involves typically leaving the house and going to pick up your booze supply, and obviously that increases social contact, and thus puts you at more risk of catching coronavirus. And I should say that we're probably all middle class here, and we're like, but you can just click on craft beer companies that will happily deliver beer and boxes of wine to your door. That's not true for everybody, and particularly some people with alcohol use disorders are relatively digitally excluded, and are not able to sort of access that kind of service, and also booze through those kind of services tends to be more expensive. So people have been going out in order to purchase alcohol, which puts them at increased risk of contracting COVID. But also, if you think about alcohol, it literally affects every body system. So add any organ after the word alcoholic, and you have a diagnosis in the ICD-10. So alcoholic gastritis, alcoholic pancreatitis, alcoholic polyneuropathy, etc. And so because alcohol can have a toxic effect on all of those body systems, it can increase your medical vulnerabilities and make you more susceptible to COVID from that way as well. So it's both the pressures of going outside, but also the physiological consequences that problematic drinking can have on you.
I mean, now you have a particular interest in deprivation of alcohol use, and you have indeed been the clinical lead for the homeless hotel drug and alcohol support service, which I think is the first pan-London commissioned drug and alcohol service providing support to our fellow citizens that don't have anywhere to sleep. So is there a link between deprivation and alcohol use?
Yes, so it's quite interesting. It's called the alcohol harm paradox. So if you compare people of high socioeconomic status and lower socioeconomic status, typically people in the higher group drink more, but actually the people in the lower socioeconomic group have more alcohol health-related harms. So they're experiencing more health harms despite the fact that they're actually consuming at lower quantities, which is really interesting. And so that's for a whole bunch of reasons, associated with low socioeconomic status. But yeah, we've tried to since the pandemic started, people who've been experiencing rough sleeping have been temporarily housed in a bunch of hotels across the capital, and it was realised pretty quickly that there was a huge amount of alcohol and drug-related comorbidity in this population, as you might expect. And so yeah, I've been running for the last 3 and a bit months or so. We're called HDAS, the Hotel Drug and Alcohol Support Service. Yeah, providing drug, alcohol, and tobacco harm reduction and support at getting people into local services and trying to minimise any terrible things that were happening with this population. It's been fun.
Fun. So, Emmert, what are you expecting to see post-pandemic? I mean, everyone's talking about an impending financial doom. Now, couple that with the negative prognostics that come with Brexit, and you have a really grim situation emerging. In an older review paper back in, I think it was 2016 or something, so Dom et al. Tried to identify the impact of a 2008 recession on substance use. Now, the results were not as straightforward as you might expect. So there were studies showing reduction in population's overall substance use, but an increase in harmful use and negative effects within specific subgroups within the society. So what are you expecting to see post-pandemic?
I think it's going to be really bad. And I think it's going to be really bad for a couple of reasons. Exactly as you've just said, it's likely that the prevalence of alcohol use disorders is going to go up because people are feeling pretty anxious, their mental health is going to suffer, but also the level of unemployment is going to skyrocket. And so unemployment and deprivation, as we've mentioned, are associated with alcohol-related health harms. And the other thing is access. Like I have no confidence that the treatment system is robust enough to deal with a huge influx of people, or that they'll be able to jump over the many hoops they have to do in order to get into drug and alcohol treatment services. I suppose the main thing, just to pick up slightly on what we were saying earlier, is that our workforce is really, really in dire straits at the moment. So yeah, we've reduced from 120 addiction psychiatrists in 2012 down to about 40 and about 12 training posts. And so without the ability to capacity build, because these services are no longer in the NHS and you can't necessarily be trained in them, we don't have a workforce that's really fully equipped, or we're not going to have a workforce in order to be able to deal with a huge increase in problems.
Let's get a bit more practical. So what is what do you think is the most common mistake that you see professionals trying to tackle someone's alcohol use? And obviously, what would you suggest?
Okay, so the thing that it's really funny, but like everyone is really good at documenting the fact that they've asked about alcohol use. They it's like drilled into a medical school, right? Like you need to ask about alcohol use. And everybody does it, and everybody writes down, and they were drinking 6 cans per week, and then they stop. So everyone's really good at reporting quantity and frequency, but that tells me nothing as an addiction psychiatrist. You could be drinking, 6 cans a week, and it'd be causing absolute havoc on your life. And you could be, drinking it all in one go as a binge, or you could be drinking it in a way that was increased risk. Or you could be spacing it out very sensibly and only have, that 6 cans a week is different. So pattern of drinking is incredibly important. So I would encourage people to not only document quantity and frequency of what they're drinking, but people's pattern and how it relates to any harms that they're experiencing. And you can do that using the Audit C questionnaire. So it's 3 questions which include quantity, frequency, and pattern. And it gives you a really good idea. If you're scoring above 4, you need more investigation about your alcohol. Gives you a really good idea about whether or not people actually do have an alcohol problem, because just sticking down the quantity and frequency of what people are drinking is super unhelpful both for you and your patient in terms of figuring out whether or not they actually need an alcohol intervention.
I know I promised to touch on your alcohol, but I can't help it. I know you're also into gaming addiction. So is there any data out there about gamers in the pandemic?
Yeah, so it's patchy. Like all data with gaming disorder is patchy. So as of when the new ICD-11 comes in 2021, gaming disorder is now officially a diagnosis. So yeah, it can be formally diagnosed. Gaming and online gambling, which are sort of intrinsically linked, have both been thought to go up during the pandemic. Obviously, people have been more at home and have been wanting entertainment in various ways. We have really rubbish data, I think, on the prevalence of gaming in this country. We have slightly better data on the prevalence of gambling. But what we do know is that so the advertisements for online gaming and online gambling have gone through the roof during the pandemic, and that's most likely increase the number of problematic or people who relapse into problematic gaming or gambling. We don't have sort of definitive figures out there for gaming disorder, but it won't have helped, or we think it hasn't helped. And certainly the referrals we've been seeing to the National Gaming Disorders Clinic have increased.
And before we close, so what are you up to these days?
A whole host of things. So we're trying to, at the moment, working with Public Health England, we're trying to link the national data set on drug and alcohol treatment systems with the national data set on hospitalisation to see how changes in individuals' treatment has impacted on their rates of going to hospital, both from a sort of individual perspective, but also from an area perspective. So are there things that you can do or modify for people's treatment journeys to avoid them going into hospital? So that's what we're trying to do, a big sort of national data linkage project at the moment, which we think would be the biggest substance misuse treatment database in the world.
Amazing. Thank you very much, Emmert. I genuinely learned a lot today. So that was it. Next week, for the last BRAINCAST of this season, we are leaving doctors, scientists, and professionals behind and open our doors wide open to welcome the gift of the gods, music. With me, arguably one of the best jazz musicians walking on this planet right now, with releases on the most iconic jazz record labels, and with a brain that oozes spirituality, the saxophone, and not only, player Shabaka Hutchings. We'll talk about what else? Music and our brains. See you next Monday at 1 p.m. Yes, I know, if I need a haircut, it will happen soon, I promise. Pospo and BRAINCAST for more learning. Over and out.